PAP therapy. This is a brief introduction. We spend a lot of time in summer on PAP therapy. Um, we'll talk about the different modalities, all of it, like what it really comes down to. Very brief introduction, so you're kind of helps, because it is such a big part of our job that I find it important to start the introduction here. Basically how it works, what CPAP stands for is continuous positive airway pressure. Essentially how it works is it delivers this continuous flow of air. That's why it's called continuous positive airway pressure. The same pressure you're breathing in with, you're breathing out against. And it's that breathing out against the pressure that's how it works. It acts as like this splint that if you think about the kind of the physiology of what happens during an apnea in the airway where the airway is floppy and collapses on itself, that resistance to the exhale is what's acting as a splint to just hold the airway open. So how I explain it to my patients is that it doesn't breathe for you. It's not a ventilator. It's not forcing you to take a breath. All it is doing is holding your airway open so that they can continue to breathe normally throughout the night. They're no longer having that airway collapse that is preventing them from breathing normally because it's just holding their airway open. The machines range in pressure from anywhere from 4 to 20 centimeters of water pressure, and the exact pressure each individual needs to keep their airway open and keep them breathing well and sleeping well throughout the night, I don't know. And that's the purpose of a titration. We start low and we kind of play with the pressures to figure out where the patient might land on. How they receive the air is basically the machine, which is, I kind of explain it to the patient, it's a smart little, it's an air compressor. It's just delivering room air. It's just blowing it at you, but it's a smart little air compressor. You connect a tube to the machine that connects to a mask that the patient wears. The mask has to fit snugly against the patient's face so you don't have air leaking from around it because it's got to maintain that pressure that the patient is supposed to be receiving from the machine. Look at that, I already said all that. CPAP is the most effective non-surgical treatment for OSA. It works for most patients. When you first look at it, it's like, wow, this thing sucks. Like, why would anybody agree to wear this? It's, it's honestly, it's not that bad. You guys will get a chance to put it on. And you'll get to feel it. The masks have come such a long way in terms of their construction, what they're made out of. They're very lightweight. There's so many different style options to fit most any need. It is the first treatment of choice because it's so effective, and it's so effective for most patients. Only, there's a small faction of our patients that fail PAP therapy either because they can't adjust to it or they just don't do well with it. But that's not the norm. Most people do really well with it. And the way I like to explain it to people too is it's not even a pill. Like, you're not even putting anything in your body, like anything like that. It's literally room air. What you are breathing right now, no oxygen, nothing else added. It's just delivered at a constant pressure. And so when I kind of explain it to them like that, because, in our culture, and it's just everybody wants the quick fix, the magic pill to make it go away, like don't make me work for it too much. And with PAP, it does take a huge contribution on our patient's part to put it on every night, keep it on every night, keep up with the maintenance of the equipment, clean it every day. So we do have to take that into account with our patients. But when I try to make it into like kind of put it in the light that it's natural. It's, you're not doing anything negative for your body by wearing it. There's no like serious side effects typically seen. There's side effects, but not like, medication side effects where you can have, a litany of whatever's going to happen. It kind of helps them more come to terms with it. The other component of it is OSA is not a disorder that typically resolves. meaning that very rarely can a person be cured from it once they have it. Yes, there's kind of two main causes to obstructive sleep apnea, weight and anatomy. And the thought being if it's caused by weight, once you lose the weight, you could cure yourself of it. And that does happen. It does, especially in like our bariatric patients. But the majority of our other patients, a lot of, even if they are overweight, a lot of it still has to do with their anatomy. So even if they lose the weight, they may still just have apnea, just not as severe as they had it when they were at a higher weight. And looking at it that way, like, a patient coming into this thinking like, I'm going to have to wear this for the rest of my life can be very overwhelming and disconcerting and dissuading. They might not want to jump into this. And I never try to say it like that. I never be like, yeah, you're going to have to wear this the rest of your life. Because I don't know. I don't know the future. But just looking at it that I try to divert them and rephrase it. Yeah, you'll probably be wearing this for a while, but I promise you'll get to a point where you want to wear it, and you actually don't like the nights that you don't wear it. So it becomes a positive part of your routine that even if it is something that you'll have for the rest of your life, it's not a negative thing. And a lot of our patients do get to feel that way, where they do feel like they don't they don't want to sleep without it. If there's nights where they travel and they thought like, I'll be fine for the one night, I'm not going to bring it. They're like, man, I'll never do that again. I don't care. It's not that bad to pack up. It's not that I'll just bring it with me. I don't care how long I'm gone for. So the three most common types of masks that we have our patients wear, we have the nasal mask that goes just over the nose. It is the very basic kind of style mask. What I say about the nasal mask is the straps are pretty secure. The way they have these kind of 4-point straps. If you have a patient that tosses and turns a lot, this mask really stays pretty stable on their face. There's not a ton of negatives with this mask, except that you do still have something on your face. Some people are very sensitive to that. And with it, you can only breathe through your nose. Not as big of a deal as you might think. When choosing a mask for your patient, you're going to try to steer them towards a nasal style mask, either the nasal mask or the nasal pillows, because most people do breathe through their nose. Maybe not at night, because if you have apnea, your airway is closing up on itself. So of course you're going to try to gasp in the air you're not getting. So a lot of our patients that have apnea do breathe through their mouth at night just so they can try to breathe. But during the day, most people breathe through their nose. If you look at most every infant, we are born as obligate nasal breathers. It's only through our lifetime of deviated septum, broken noses, allergies, whatever, masks, that we have gone to breathing through our mouth, right? On most natural, normal circumstances, we breathe through our nose. And I rely on that with the CPAP. Most people that can breathe through their nose at night or during the day can breathe through their nose at night, because this bypasses the need for them to breathe through their mouth, because it's going to be giving them enough air that they don't need to gasp for air through their mouth. So most people do well on a nasal mask. You kind of have to sell them on it. Like, people are very skeptical, thinking, I'm going to do fine with, I need a full face, the one that I can breathe through my mouth, because I definitely breathe through my mouth at night. Most people do fine with the nasal. The full face goes over the nose and the mouth, and it's the only mask that really gives the patient the option to breathe through their mouth. Some patients, you have to go with it, because if they really are mouth breathers, like they cannot breathe through their nose, chronic allergies, whatever, we have to go with it. The problem with this mask is it is a lot bigger and heavier on the face, not that as comfortable. The other thing of it is safety. So with a nasal mask, if you were to lose power at night and their machine turned off, all they have to do is open up their mouth. I mean, you can still breathe through the mask. It's not like, so have you ever put on a fire mask, the firefighter's mask? It's like airtight and you can't breathe. If it's not connected to air, you can't breathe. It's not like that. you can breathe around it. It's just you have to really suck in to get air. If you were to lose power on this, they would feel that panic a lot quicker. And what were to happen if a patient were to vomit during the night in this mask compared to this? Most people, we wake up if we're going to get sick, but what if you didn't? The risk of aspiration is a lot greater in this one. So safety issues on this one. Most physicians want to see you try a nasal mask with the physician first, or if you went straight to a full face mask, documenting why. Because there will be patients, you look at them and you're like, you are not breathing through your nose at all. Like, I'm not even going to bother trying. You just have to document it well. Nasal pillows fit just inside the nostrils. They're the most lightweight kind of open mask that we have. So if you have somebody that's claustrophobic, I go towards this one. Very minimal. So the pros of this one is how minimal it is, how lightweight it is. If a patient were to have facial hair, we don't have to worry about the fit of it versus, the other ones. You need to make sure that you have a nice seal between the mask and the skin. So facial hair can interfere with this. It doesn't matter how big of a beard or a mustache the person has. It really just comes down to these pillows fitting inside their nostrils. Cons of it is there is less to it, which means that if a patient were to toss and turn a lot, it can shift out of place a little bit easier or slide up a little bit easier. Especially like these style masks, you have very smooth hair or a very flat back of the head, it can slide fairly easily. Some women might, strategically do a ponytail or a bun to sleep in to hold the strap in place, things like that. The other component of it is that even though the machine delivers the same level of air and pressure that we hook up to, regardless of whatever mask the patient chooses, with these style masks, the air is delivered into a mask that the patient then breathes in. This mask, it delivers it directly into the patient's nose. Some people are sensitive to that. The other thing is some people do get like sores on the inside of their nose. I tried CPAP because I tried it for a couple nights just to be able to get a better idea of teaching you and teaching my patients and all of that. And I thought, like, I am a pillow girl. I cannot have anything on my face. I just couldn't stand it. So I went to nasal pillows, and within an hour and a half the first night, I woke up ripping it off because it just felt like something was pushing on my septum of my nose. I thought maybe it was a fluke, tried it again the next night within an hour. And what I can't see on me is that my nose, my septum comes down slightly below my nostrils. Can you guys see that? Okay. So pillows really aren't a great option for me because it makes it so that because that's more protruding, that it's kind of pushing on them a lot more. It's all these physical nuances of every single face that we look at that helps us there's no way I can teach it to you in a classroom. It's just going to be as you get out in the field, continuing to work with people, work with text, and looking at all the masks we have. It'll help guide you to what mask, to kind of gear the patient towards. Ultimately, it's their choice. They're the ones that have to sleep with it. They're the ones that have to put it on every night. It is their choice what mask we go with. We're here to help use our technical proficiency to kind of guide them on how and what to choose. We need to try to find the lowest PAP setting that treats the patient, that eliminates the apneas, hypopneas, RERAs, keeps the saturation at a healthy level. We want to find the lowest possible setting that does all that. The higher we go, the more side effects the patient can experience, and it's just like we don't need to go that high. Let's try to go as low as possible. That's what's known as the titration process. We start low and we slowly increase the pressure until we find that magic number. So we slowly turn it up, and we are still doing the full setup of wires. Just instead of using the flow sensors, the thermal sensor, and the pressure transducer, you're putting a CPAP mask on them instead. We're not putting those things on underneath the mask. We are able to get our flow, a flow channel through the CPAP machine because they're hooked into the CPAP, the whole system. Ideally, we want to eliminate all the respiratory events, but we also want to make it a point that the patient's going to use it. Compliance is a huge issue. So sometimes if the patient's uncomfortable at certain pressures and we might have to turn it down, they might have like mild, very mild apnea at the low pressure, but if they're better able to tolerate it, it's like that trade-off that you kind of have to play. So ideally, we want the patient to tolerate it, feel comfortable. We want to normalize their sleep. We want the RDI to be less than 5. We want the SAT to stay above 90. We want the arousal index to be less than 5. We don't want them snoring. That's an ideal world. It doesn't always happen, but the really lovely thing about sleep is we get it for a lot of our patients. So there's that definite sense of accomplishment when we're doing these studies, because most patients we're able to achieve this for them. There's a small subset of patients that we aren't, but you get that feeling of like, yep, I did my job, I got them treated, hopefully they're going to feel the difference and it's going to start making a difference in their life. Start low, wait till the patient falls asleep to start changing the pressure, because we're changing the pressure and titrating the pressure for things that happen while they're 2 centimeters of water pressure. So most patients I start around 5. I usually go as conservative as possible with my titrations, meaning I'll increase by 1, wait about 20 minutes, increase by 1, kind of see what happens. If the patient's having like back-to-back respiratory events, I will be a little more aggressive. I might increase increments of 2, so go from 5 to 7 to 9, at least until I break them open to kind of get them a little bit more stable with their breathing and then slow it down. And the reason why is I've had patients that are super severe. When you first start the night out, if they're still having back-to-back apneas, what I've had happen with patients is they've woken up and just ripped the mask off and are like, this thing is suffocating me. I woke up gasping for air. This thing suffocated me. And it's like, no, you actually suffocated yourself. It's just this pressure isn't high enough where it needs to be yet. And I don't want that even association to happen where they attribute the mask, the machine, and have that negativity about it, that it's what's causing it, because it can create that panic in them. So I try to be a little more aggressive until I at least stop the back-to-back respiratory events, and then I'll slow it down. You want to give them an ample amount of time at each pressure because it can take time to adjust to it. Watching to see what kind of respiratory events they're having, if they're still waking up a lot, if their oxygen is in a good range, and you kind of keep going. Again, we want to find the lowest possible pressure, but if we don't go high enough, the patient's still going to have a lot of respiratory disturbances. But if you go too high, you're going to create a lot more side effects and issues, and we can even go so far as knocking their drive to breathe out. So if you are titrating and all of a sudden you start to see a lot of central apneas, you got to back it down. You've knocked their drive to breathe out. You've over-titrated. You want to find the pressure that gives the patient the best overall sleep in all positions, all sleep stages. And so kind of that golden goal to shoot for is REM supine sleep. Remember, on your back is when your apnea tends to be worse, and when you're in REM sleep, events tend to be more severe. If we can find the pressure that treats them all positions and specifically REM supine sleep, you've done your job for the night. When you go too high on the pressure, again, you can knock the drive to breathe out, cause centrals. You can also start causing the patient to wake up a lot more because they're feeling that pressure, they're getting uncomfortable. You can have them start ripping the mask off, like, oh, this thing is in. Sometimes when patients rip the mask off, they're not even aware that they're doing it. Like, you've done stuff while you're asleep and you have like a half awareness that you're even doing it. So you can't really get mad at them for doing it. They're reacting to what's happening to them. Another modality that we can try is known as bi-level PAP, whereas CPAP is continuous. It's one single pressure, same pressure you're breathing in, you're breathing out against. BiPAP uses 2 pressures. We have an inspiratory pressure and an expiratory pressure, and you'll see it expressed as IPAP over EPAP. So, 8/4, 8 is the inspiratory, 4 is the expiratory. IPAP is always higher than EPAP, so the inspiratory pressure is always higher than expiratory, which you just kind of have to think about the natural action of breathing. Inhalation is an active process, so you're breathing in with, and then exhalation is a passive process. So that's where that same thing, BiPAP kind of mimics that, where it just drops the pressure so it can be more of an active process. So the patient isn't breathing out against as high of a pressure when they exhale. The difference between inspiratory and expiratory pressure has to be at least 4 centimeters of water pressure. So whereas like if you have an inspiratory pressure of 9, the expiratory has to be 5 or below. You can't have it at like 9 and 6. They have to be at least 4 pressure difference. Inspiratory pressure holds the airway open, kind of gives that augmented tidal volume, lets the patient breathe in a bigger volume of air, so it can increase their saturation, and it's mainly used to treat like the hypopneas, the RERAs, that type of thing. Whereas your EPAP or your expiratory pressure is what holds the airway open throughout the entire respiratory phase. So you don't have that collapsing as the person exhales. And so that's mainly used to treat the obstructive apneas if we're using to treat both. BiPAP works well for patients that have central apneas because you can play around with that split between your inspiratory and expiratory pressure, and it can kind of help initiate the breath if the patient were to fail to initiate the breath. If a patient doesn't tolerate CPAP, so once you get the CPAP pressure up to a certain level, it's standard for most labs to make the jump over to BiPAP. So that way, like CPAP levels, we're talking like 15 and above, that's a lot of pressure to try to breathe out against. So most labs have standards in place that have you to make the jump to BiPAP to make it more comfortable, and for the patient, they're better able to tolerate because they're not breathing out against such high of a pressure. The reason why we always start the patient on CPAP, unless if we have an order, is because cost is one thing. And I know it's like, well, let's put the patient first, but it is a huge thing. Until you guys will do a rotation in DME, durable medical equipment, where you're demonstrating the machine to the patient, and it having the very first thing we do when we sit down with these patients is explain the cost of their equipment, because that's the first that has had made people make the, change their decision about whether or not they're going to follow through with therapy. A CPAP machine typically costs around $1,500. A BiPAP machine costs about $2,900. So in order to give them BiPAP, number one, we have to prove it to the insurance company that the patient truly needs it. And you got to think too, like the way the insurance companies, a lot of them are structured nowadays, instead of a person paying like a set copay for medical equipment, a lot of them have to pay like a percentage. So CDPHP, huge payer in this area, they have different plans where you might pay 20% of your equipment or 50%. And the patients have to pay 50% to get their CPAP machine. They have to pay $750 out of pocket just to get the initial equipment. That does not include replacement parts, supplies, anything like that. To get the BiPAP, they're paying $1,450 just for their equipment. That's a lot of money, even 20%. So for a CPAP machine, a CDPHP patient that has a 20% copay has to pay $300 for a CPAP, $600 for a BiPAP. Explain that to a person like, yeah, I'll take the cheaper one. On top of that, I know it's like everybody's like, well, if BiPAP mimics the natural pattern of breathing, shouldn't we be doing that for all our patients? Isn't that the better therapy? Blah, blah, blah. It's not. It's not. Most of our patients do really well with CPAP. It's comfortable. They tolerate it. They do really well. In lab this week, I'll have you guys put on both. And what I've found is when we make the jump to BiPAP, it actually, while it mimics our pattern of breathing a little more naturally, it actually can be a little more uncomfortable. Like I've had people complain of claustrophobia with BiPAP because of that drop in the pressure. It almost feels like it might be sucking the air out. So they actually are a lot more comfortable with CPAP. Most patients do really well with CPAP, which is why we try to make it work for them. It's cheaper, it's simpler, and it's usually more comfortable. When we make the jump to BiPAP, so it's within our scope of practice to be able to kind of work on these different modalities without having to call the physician. We can change the pressure, we can do everything. Like that's what we do. We don't need to call a physician to get an order change. Like, okay, I need to up the pressure. Can I do that? Like, That's what we're allowed to do it without an order. And we can make the jump from CPAP to BiPAP. We can switch between these modalities without having to call the physician either. You just have to look for the signs for when we're going to do it. If the machine is maxed out, what that means is most CPAP machines can operate on pressure levels between like as low as 4 and as high as 20. I've had patients get up to a CPAP of like 18, 19, 20 and still have respiratory events. It's a lot of pressure. The BiPAP machines can get as high as 25 over 20, so an inspiratory pressure of 25, and the EPAP is at 20. We can go a little bit higher on pressures with BiPAP, which is why we might make the jump to BiPAP as we start to get super high. If the patient's not tolerating CPAP, I've had like a couple instances where the patient just could not tolerate CPAP. They're like, this is just uncomfortable, blah, 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 and I'll start them on BiPAP. Basically what I did in that instance is once they fell asleep, I switched them back to CPAP to see how they did once they were asleep, and they did fine. And so I titrated them on CPAP, and then I made the jump back to BiPAP just to see what pressure they would end up on if the patient was really adamant that they couldn't tolerate CPAP. But I wanted to prove it to myself, I wanted to prove it to the physician, and I wanted to prove it to the patient that they could tolerate CPAP. Just while they were awake, they had such a mental, like, I can't do this. We can switch to BiPAP. Say we've done our CPAP titration, we've got them to a pressure where we've eliminated respiratory events, but their saturation is still hypoxemic. It's still kind of like riding 80s, whatever. I can switch them to BiPAP and try to play with my IPAP-EPAP split and kind of augment their tidal volume to try to just get their saturation, just eke it up enough to get it out of hypoxemic range so that I don't have to add supplemental oxygen. Sometimes it works, sometimes it doesn't. I try it because supplemental oxygen is a whole new set of medical equipment and costs and hassle that if I can avoid it for the patient, I'm going to try to do that for them if it's just a matter of switching modalities. Neuromuscular diseases. So if you have a patient that has some type of neuromuscular disease that makes it difficult to exhale against this higher pressure or continuous pressure, you kind of have to go with BiPAP because it is easier for them to breathe with. So how we do the titration, where CPAP is fairly simple, it's one pressure. You kind of keep turning it up slowly until you eliminate the respiratory events. BiPAP is 2 pressures, so it's more complex of a titration. We need that pressure split of at least 4, and you can't go higher than 10. So you can't have a 10 pressure difference. You can't have more than a 10 pressure difference between your inspiratory and expiratory, which means like say EPAP is at 10, IPAP can anywhere between 14 or 20. Make sense? Basically, these 2 pressures can be set independently. How you start it is you have a 4 split. You keep moving them up together until you eliminate the apneas, and then you kind of plant the EPAP there, and then you can keep going up on the IPAP until you eliminate all the other respiratory events, high pops, RERAs, snoring, saturation, up and until you eliminate all those, or if you hit a 10 split, like there's 10 pressure difference between IPAP, EPAP, then you have to keep going up in a stepwise fashion again. Make sense? That's the textbook. Now let's talk about real world. You will get patients that don't tolerate certain pressure differences or that really tolerate a certain pressure IPAP, EPAP split. And then once you kind of deviate that from that, they kind of don't do as well. Every titration, you have to treat it individually. Like I've had patients, they did really well. Like I was titrating them on BiPAP. I had a 6 split between IPAP, EPAP. And as soon as I like kind of deviated from that, they just didn't tolerate it. So that's what I documented, and I kept them at a 6 split and kind of titrated BiPAP that way. It's just a matter of kind of titrating. PAP is an art form. You want to be conservative, take your time, you have all night to do it, and it's just something that's going to come with experience. Okay. We can further go into different BiPAP modes, different ventilation types. I'm touching on it very quickly here. We pretty much beat PAP to death over summer. So spontaneous mode is the mode that we use most often, which means that the patient is what is initiating the machine to alternate between IPAP and EPAP. It's just going off of their breathing pattern. We can do timed mode, which means that it's almost like a ventilation device where the machine automatically is going to switch between inspiration and expiration, and it breathes for the patient. Like they can't initiate their own breath. They have to breathe with the machine. Pretty uncomfortable, so it's really only used in really severe cases. What's used more often is spontaneous with a time backup, which means the patient can initiate the machine from alternating between inhalation and exhalation. But in the instance of like central sleep apnea where they fail to initiate a breath, the machine will kick on and initiate the next breath and automatically like start delivering the IPAP and kind of make them keep breathing. Part of our job is testing the pressures, the machines, to make sure test the integrity of the machines, and we can do that through a manometer. It's essentially like you hook it up to the end of a machine and you occlude it, and like say the machine is set at a CPAP of 10, you just want to see that manometer read CPAP of 10. If it's more than 2 centimeters of water pressure off, it means that the machine is no longer delivering the pressure it's set to deliver, and it might be time to take it out of commission. We routinely, I think it's like a monthly thing, we have to calibrate our machines to make sure that, test them to make sure they're delivering the pressure that it's set to deliver. This one is an analog kind of version of the manometer. This one's digital where you actually get a readout, an actual number. Basically, as long as it's within 2 centimeters of water pressure for what it's supposed to deliver. There's an additional, I'll talk about it now. There's an additional setting that we can play with on the machines. That's a comfort setting. It's called C-Flex. Essentially what it does is because exhaling against the pressure can be uncomfortable, we can play, it's within our scope to be able to play with this extra little setting where it basically backs off on the pressure at the end of exhalation, makes it a little more comfortable for our patients. Add it if you need it. When you're pressure checking a machine, if that comfort feature is on, the machine's not gonna pressure check. So it's something to always keep in mind, because I actually, one of the things I do in prisons is I will check the integrity of their machines periodically, and you have to make sure you go in and turn the C-Flex off, because I almost decommissioned a patient's machine and like, okay, it's time to get a new one. Here's, causing insurance company to pay, and the patient to pay all this money to get a new machine. When their machine was still working fine, I forgot to turn off the thing. And I think I actually remembered it right at the end of the appointment. I'm like, you know what, let me check it again. And it was fine. These machines tend to last long. They're motors. They're good little motors. I've seen machine last a decade or more. I think my dad has his original machine. So we're talking like his machine is like 12 or 13 years old. It's still going, you know. Patients can and do experience side effects from PAP, specifically like the issues with breathing in the air. It can be irritating to your nasal passages, causing dry nose, sore throat. What happens when you breathe in dry air, like out for a prolonged period of time, is your body's going to try to react to it and protect your nasal mucosa by producing more congestion. So that's where you get the congestion, runny nose. It can cause sneezing, dry mouth. In severe cases, some people might get nosebleeds if you let it go bad enough. Because the air can be an irritant, and your body is going to respond to try to protect your nasal passages, so producing excess mucus. It can develop over time and get worse over time. Same thing over the night. So the patient might be fine in the beginning of the night, and then you'll notice they start, you had them set to a good pressure, and all of a sudden, kind of towards the last hour or two of the study, they start snoring again. And you kind of have to go up a little higher in the pressure. Well, it's probably because their body is now responding to the air, and they're getting more congested as the night goes on. So we need a little bit higher pressure to kind of overcome that. It's standard. Pretty much everybody gets a heated humidifier with their machines now. So they put in distilled water, and it humidifies the air that they're breathing. The patient can adjust the humidity setting based on the heating setting, which means it can be seasonal. Like in the drier months, they can turn it up, turn it down in the summer. Some patients in severe instances, they might get like nasal sprays prescribed to them, things like that. If the issue is a mouth leak and they're in nasal mask, we know that they're opening up their mouth when they shouldn't. One thing, we can either switch them to a full face so they can breathe through their mouth, or add a chin strap, which is essentially like, it's a jock strap for the chin. That's really all it is another piece of fabric that goes around the chin and just holds it up. It doesn't make it so you can't open your mouth, but it makes it a lot less likely that you're going to open up your mouth. Other issues, we can get skin irritation, especially if the patient isn't cleaning the machine or the mask properly. Um, if the mask isn't fitting them well, it can cause irritation, and especially like the way where the mask is, if the air is going into their eyes, it can cause eye issues, conjunctivitis, things like that. Common issue too is swallowing the air, so it can cause abdominal bloating, aerophagia. With aerophagia, or the swallowing of the air, basically when a patient passes gas in the morning, it goes away, but it can be that really uncomfortable gas bubble that they get. So it is something that we take seriously for the patients. Like, I'm not just gonna be like, oh, fart it out, you're fine. Usually we'll just turn the machine down a little bit to try to lessen how much air they're swallowing. So if you have an ill-fitting mask, if they're not cleaning the machine, is so important. It's so important, especially they're cleaning it properly, they're not using chemicals, because anything they clean the machine with, they're breathing in, it's going directly on their skin, so no chemicals. It has to be a very natural process, them cleaning everything. And if they don't, like the way I say it to my patients, like, you change your underwear every day, well, this is on your skin, you need to clean it every day. Just get the skin oils off. I always re-stress the importance of cleaning and go through the cleaning procedures with them at most every appointment, because it is easy to start to slack off on it, or if necessary, if the mask isn't fitting them, time to find a new mask. It's one thing, the mask might have worked well for us when we were in the lab with them, but once they get home, things can change once they get home. Maybe we need to choose a different mask. If the patient's having trouble acclimating to the machine, we have instructed the patient, try putting it on when you're just watching TV. Try just wearing it for like a little bit at a time and build up to sleeping the whole night. Um, I'll tell sometimes, like, try sleeping with it for as long as you can. If you absolutely can't sleep with it the whole night, well, eventually, oftentimes patients can build up to sleeping with it the whole night. If they're having difficulty tolerating the air, there's a lot of different kind of settings we can play with the machine. There's a ramp feature, which means that it basically ramps the pressure that they're getting. If the machine is set, if their prescribed pressure is like set at 10, well, maybe putting on at 10 when you're wide awake, that's a lot of pressure coming at you. So they can hit the ramp button, which essentially over a set period of time, it drops the pressure to like 5, and over 20 minutes, it'll incrementally increase the pressure up to their prescribed pressure, with the thought being, by the time it gets up to your prescribed pressure, hopefully you're asleep. If not, you hit the button again. If the patient is complaining of dry, stuffy nose, you really need to look at the humidifier. Maybe they're not, putting water in it. Maybe it's not set appropriately, anything like that. Or if really severe cases, explore the option of adding in nasal sprays. If the patients are claustrophobic, I have had patients like truly freak out when you try to put this thing on them, like freak out. Um, Sometimes it's just a matter of letting them hold the mask and have that control to take it off when they need to. And once they've fully acclimated to it like that, then I'll try putting the straps on. You just kind of got to work with them. Sometimes you can get, if they're cleaning it properly, whatever, there's a lot of different things that can cause skin irritation having this on your face. They do make like little cotton thingies that you can put, little very thin pieces of cotton that fit. They look like a triangle almost with a hole in the middle, so it goes right over your nose. And then you put the mask on top of it, which means that the mask isn't actually touching your skin, it's touching the cotton. Some people are just really sensitive to the silicone of the mask. There's also a thing called mole skin. Have you ever seen that in like the first aid area? It's almost like a very clear, thin, almost looks like a bandage. Like you can cover, like if you had stitches or something, you can use it to cover. Well, you can use that and kind of cut it out and put it on your skin, so the mask isn't actually touching your skin. It's touching this like thin and like barrier kind of film that you can get. If the patient has trouble falling asleep, again, it takes time, making sure that they're going into it aware. If you have trouble falling asleep, just give it some time. Waking up with a dry mouth, we can either add the chin strap, we can increase the humidification, things like that. If the patient takes the mask off during the night, again, totally normal, and they might not even be aware that they're doing it. In the sleep lab, we're there to go in and put it back on them, but when they're home, they might not even wake up and then just not even realize and wake up in the morning and be like, oh, when did I take my mask off? So working with them to either find a mask that they're comfortable with, figuring out why they're unintentionally taking it off. I always get annoyed with this last one if the patient complains about the noise of the machine. It's like, really? It's a lot quieter than you're snoring. But some people are very sensitive to that. What you can do is you can either get like a mouse pad and put it underneath the machine, or put a towel underneath the machine so it's not setting directly on a hard surface, and that can kind of dampen the noise. But the machine itself is honestly incredibly quiet. Maybe like if the mask, if there's air escaping from the mask, it can cause a whistling. So just working with them on finding a mask that works well for them. With PAP therapy, it is not a cure, it's a treatment, which means that the patient has to wear it every night in order to gain the benefit. You can't wear it for a few nights and then, okay, I'm good, I don't have to wear it ever again. It's important the patient knows that they need to wear it in order to get the benefit from it. And the biggest hurdle that we encounter is compliance, actually getting our patients to use the treatment and use it for most of the night. And a huge component, they've done a ton of studies on what impacts compliance. And the number one thing is patient education, how educated they are about their disorder, on the importance of treatment, the importance of keeping it clean, on all of it. They need to, it's them doing all this. We only have them for a couple nights. After that, they're expected to clean it, to put it on, to do it all. So making them sure they're an integral part of their own health care, and their, you know, making sure that they know why they're doing it. That's one of the things I'm huge about. I'm huge about patient education. We are in this subsect of medicine that we have the benefit of having a lot of like quality time with our patients. Look at how much time it does to do a setup. Obviously I'm going to explain what I'm doing, but there's time in between that where I'm going to use that time to educate the patient, talk to them about what OSA is, talk to them about the treatment options, make sure they're just so well versed in it all, and repeat that every time I see the patient, because how many times do I need to repeat myself here before it finally really sinks in? You know, we're all human. It's not, you need that repetition sometimes. Same thing with our patients. I try to include their family in it, so their bed partner, anybody, a caretaker, whatever, because they'll be a part of it too. Especially like I've had wives be like, yeah, teach me how to clean it because he's not going to do it. And they're not even on PAP therapy, but they're the one they know their spouse, and they'll take over for it. Making sure that the mask fits them well. Taking the time to desensitize them to it, like letting them breathe with it, sit with it, kind of get used to it before, like, okay, now go to bed. Because could you imagine walking to the lab, I'm going to slap, 35, 40 wires on you, and then I'm going to slap this mask on your face that you've never worn before, that feels completely foreign and alien to you, and then good luck, good night. You know, like I'm going to spend 20, 30 minutes explaining PAP, explaining their diagnosis, explaining everything, and letting them sit with it and breathe with it. You guys see, I'm really good at running my mouth. I can run my mouth for 4 hours straight. The more I run my mouth, the more I distract my patients. And so I kind of use that tactic when I'm explaining PAP and first getting it on them, because it does take away, because when you first put it on, it will kind of take your breath away a little bit, and it can cause your ears to pop. It just, you'll see, it feels very foreign. Doesn't take long to get used to, but that initial putting it on, it's like, oh. And so the more I run my mouth and just keep talking to them and explaining what they're feeling and what's going on and all of that, the more they're like trying to listen to me and kind of distracted about what they're feeling. And make sure the patient's involved. They need to be happy with their mask. I'm not going to just say, this is the one I'm going to use for you, because I think no, they need to help me choose it. We can do split nights, which means we're doing both the baseline and the titration in a single night. Most insurance companies require that the patient, during the first baseline portion of the night, you need at least 2 hours of sleep. And from that, we can estimate what their RDI is, and you need an RDI of at least 30 before you can initiate the treatment portion. You have to have at least 3 hours left in the night to be able to do the titration portion. Sometimes the studies are ordered as a split night, or sometimes we have the ability to make the jump to a split night based on what we're seeing. Like we have emergency split night protocol. If St. Peter's, if my RDI was higher than 60, I didn't need to call the patient or the physician. I didn't need to wake them up in the middle of the night. I could go ahead and initiate treatment. I had a standing order for that. A lot of labs do that with certain, like once a patient hits a certain severity, we need to get them treated as soon as possible. Just you got to follow your lab protocol. The advantages of a split night is they're only with us for one night. So less money, less costly insurance, less time on the patient, and it's more kind of fast tracks the treatment. They don't have to wait to come back for a second study before they figure out what pressure they need and moving forward with PAP therapy. But the disadvantages are we are limited. You know, we are significantly cutting the amount of time that we can look at the bigger diagnostic picture to get an idea of what's going on with the patient. We are limited with the amount of time that we can try to titrate the PAP, and sometimes you just run out of time. You know, it's the morning, you got to get them up, and I haven't found that perfect pressure for them. They've also found that split nights compliance can decrease when their titration is done via a split night versus a full night titration, because they don't have as much time to acclimate to it as they would during a full night titration. First night effect, which is that first night they're in the lab, they can have, you know, worse sleep. First night effect is worse on their first night, and if we're doing everything in the single night, it can kind of impact the quality of the study. But honestly, if you're doing like an emergency split night and you have a patient that's so severe, usually as soon as you get that PAP on them, oh my God, they just take to it like a fish in water because they're just so severe, and it's like their body is so air hungry and so sleep deprived. Auto PAP is a modality that has gained a lot of popularity, especially with COVID. It essentially, the machine, instead of setting a set pressure, you set a range of pressures, and the machine fluctuates within that on its own. It's breath by breath, and it picks up if the patient's starting to have any type of upper area resistance or snoring, and it'll increase the pressure as needed and back off as needed as well. Some labs have kind of gone towards that instead of doing an in-lab titration, especially with COVID and all the safety precautions needed for COVID. It also gives the patient a little bit of leeway. So say they did come in for a titration and we kind of found like, well, they kind of did well on this range of pressure, like they could do well. Well, we can set the auto PAP to deliver that range of pressures to kind of give the patient a little more auto kind of leeway in terms of what pressure they are. It can help if they're not really tolerating it well, which means the machine can start low and only deliver pressure as it's needed, which is helpful for a patient that might have positional apnea or REM-related apnea, meaning it'll only kind of amp up the pressure when they're on their back, or it'll only amp up the pressure when they go into REM when their apnea gets worse. Make sense? Back off when they don't need it. This is that pressure relief ventilation. Essentially, it's that kind of comfort setting that backs off the pressure at the end of exhalation. We do have to be sensitive to our patients. It is a huge lifestyle change. Just think of how married you are to your sleep habits right now. I sleep with this pillow. I sleep in this position with this blanket, with this on, or like how you are so set in your ways. And then we kind of throw this to our patients and be like, well, screw all the habits you formed already. Now you've got to form some new ones because this is going to completely throw a wrench in those plans. In making sure our patients understand the importance of it, that even skipping it for one night, you know, some patients will be like, well, I've had apnea for this long before I finally figured out I had it. What's one night going to be? But it can have detrimental consequences on their blood pressure, on their heart, everything. And giving the patient the sensitivity they deserve, and that it can take time to adjust to this. I get that. I understand it. I appreciate it. And just continuing to work with them until they feel comfortable about it. Questions?